When human extremities are exposed to dropping temperatures, the body naturally conserves heat by restricting blood flow to the skin. But in some individuals, that cold exposure triggers a sudden, drastic vascular shutdown, an episodic digital ischemia that drains the blood directly out of the fingers. This specific event is clinically defined as Raynaud's phenomenon. It presents as a bilateral, episodic ischemic attack affecting the upper limbs. These attacks require a precipitating factor to initiate the vascular spasm. Moving into a cold or cool damp climate is the primary environmental trigger, though intense emotional stress can also initiate an episode. Demographically, this hyperreactive response is heavily concentrated in specific populations, primarily affecting young females in their teens and 20s. This diagram shows the typical anatomical distribution of a Raynaud's attack. You can see the affliction zones are strongly concentrated in the upper limbs over the lower limbs. Notice specifically that the fingers are fully shaded, but the thumbs are left completely unaffected. This sparing of the thumb is a classic clinical presentation. The underlying mechanism driving this localized blood loss is an abnormal sensitivity within the smooth muscle of the arterioles. They hyperreact to cold stimuli, forcefully constricting and cutting off downstream microcirculation. Because this hyperreactivity is episodic and localized, a patient sitting in a warm examination room will likely show perfectly normal baseline blood flow. The diagnosis, therefore, relies entirely on taking a precise patient history rather than observing resting vascular states. This horizontal timeline illustrates the classic triphasic color change that occurs during an attack. It moves through 3 progressive stages: syncope, asphyxia, and rubor. While this full 3-step progression is the textbook hallmark, we only see it in about 1/3 of primary Raynaud's cases and 2/3 of secondary cases. The attack initiates with stage 1, the stage of syncope. The arterioles constrict violently. This chokes off arterial blood, causing the affected digits to blanch white, creating a clear-cut circumferential demarcation line of severe pallor. Next is stage 2, the stage of asphyxia. The capillaries dilate downstream of the blockage and fill with static, deoxygenated venous blood. This pooling causes the skin to develop a distinct bluish discoloration, or cyanosis. Finally, the attack passes, and the patient enters stage 3, the stage of recovery, or rubor. The arterioles relax, allowing oxygenated blood to rush back in. This reactive hyperemia visibly engorges the tissues, turning the digits a deep red. This aggressive return of circulation brings distinct sensory symptoms. The initial transient numbness from the blanching phase gives way to tingling, burning, and often a severe bursting pain in the fingers as the tissues rewarm. While we focus heavily on the hands, this vasospasm is systemic in nature. The same exact triphasic sequence can restrict capillaries in other exposed extremities, affecting the nose, ears, and tongue. Mapping this precise sequence, pallor, cyanosis, and rubor, proves that the patient is experiencing a true mechanical vasospastic attack rather than a normal physiological response to cold weather. Once the phenomenon is identified, the clinician faces their central diagnostic challenge. They must distinguish whether the patient has primary Raynaud's phenomenon or secondary Raynaud's phenomenon. Primary Raynaud's phenomenon, or PRP, is an idiopathic condition. This means the vasospasms occur entirely on their own, with no underlying disease causing them. This benign form accounts for the vast majority of cases seen in primary care. PRP presents symmetrically across both hands and has a massive demographic density in young women, affecting up to 20 to 30% of that population, with a 9-to-1 female-to-male ratio. This side-by-side comparison shows the defining diagnostic boundary between the two forms. Look at the primary column on the left. Despite enduring frequent ischemic attacks, the fingers remain structurally intact. The absolute hallmark of primary Raynaud's is the complete absence of trophic changes or permanent tissue damage. Secondary Raynaud's phenomenon, or SRP, shifts the clinical picture. Here, the vasospastic attacks are not occurring in isolation. They are symptoms triggered by an underlying systemic disease or an external factor. SRP is heavily associated with autoimmune connective tissue disorders. These include systemic sclerosis, Sjogren's syndrome, and systemic lupus erythematosus. The secondary form can also be induced by external, non-autoimmune triggers. Obstructive vascular disease is the most common cause in adults over 60. It can also stem from occupational hazards like hand-arm vibration syndrome or from taking beta-blocker medications. Clinicians look for specific clinical signs to identify SRP. The tissue damage is visible. Patients often present with sclerodactyly, tight, puffy skin around the fingers, along with digital pitting scars or even gangrenous patches on the fingertips due to superficial necrosis. Crucially, a patient can present with secondary Raynaud's attacks up to 2 full decades before the rest of their systemic illness fully materializes. Identifying the presence or absence of trophic changes determines the patient's pathway. It shifts the prognosis from benign lifestyle management directly to urgent, specialized rheumatological intervention. During a standard physical examination of early-stage cases, a clinician palpating the hands will note that the skin feels cold to the touch, but the peripheral pulses at the wrist will feel perfectly normal. To verify that the macrovascular supply to the hand is actually intact, clinicians use the Allen's test. This anatomical map isolates the radial and ulnar arteries feeding into the superficial palmar arch. The Allen's test is a mandatory procedure to detect distal arterial disease in the upper limbs. The test begins with a compression phase. The patient clenches their fist to push blood out of the hand, while the clinician simultaneously compresses both the radial and ulnar arteries at the wrist, completely occluding arterial inflow. Next is the release phase. The patient opens their hand, which will appear blanched. The clinician then releases just one artery, in this case the ulnar. If collateral circulation is healthy, blood will flood the superficial palmar arch, and normal color will rapidly return to the entire hand. If the patient is experiencing asymmetrical Raynaud symptoms, affecting one hand worse than the other, the clinician must also check blood pressure in both arms to rule out structural blockages higher up in the arterial tree. The examiner then meticulously evaluates the finger pulps. They are looking for subtle signs of poor tissue nutrition, like small hacks, wasting of the finger pulp, or digital ulcers. Finding any of these strongly indicates secondary Raynaud's. Because the visual signs of vasospasm are transient, they are often gone by the time the patient reaches the clinic. The most effective diagnostic practice during history taking is simply to ask the patient to photograph their fingers during an active attack. A clear photograph showing well-demarcated blanching at the knuckles, paired with a functionally normal Allen's test at the wrist, isolates the problem. It confirms the condition is a microvascular vasospasm in the digits, rather than a macrovascular occlusion in the arm. Once Raynaud's is confirmed, the immediate priority in the management pathway is ordering special investigations to definitively rule out a secondary autoimmune cause. This clinical dashboard lists the specific blood work required. A hemogram must be run to check the erythrocyte sedimentation rate, or ESR. The lab will also screen for rheumatoid factor, measure anti-nuclear antibodies to check for connective tissue disorders, and conduct a protein electrophoresis. To evaluate the physical vessels, clinicians utilize digital plethysmography to map digital blood pressures, alongside arteriography to visually map vessel integrity and locate any physical obstructions. If the condition is primary, the first tier of conservative management is strictly non-surgical. Patients must adopt lifestyle adjustments, avoiding unnecessary exposure to cold, moving to warm climates if possible, and entirely eliminating tobacco smoking and occupational hazards like vibrating machinery. If lifestyle adjustments are insufficient, management steps up to the pharmacological tier. Clinicians prescribe vasodilator drugs designed to force the vessels open, utilizing medications like reserpine, methyldopa, and phenoxybenzamine. Calcium channel blockers, particularly nifedipine, are also frequently deployed. By acting as calcium antagonists, these medications directly reduce the sensitivity of the arterial smooth muscle to cold stimuli. These conservative and pharmacological treatments are entirely focused on symptom mitigation. They elevate the threshold required to trigger a spasm, but they do not provide a definitive cure for the underlying vascular hyperreactivity. When conservative measures and aggressive pharmacotherapy completely fail, and the patient suffers from debilitating pain or severe necrosis, operative treatment becomes the final option. However, the resulting vasodilation often only provides temporary relief. The procedure is known as a cervical sympathectomy. Surgeons access the sympathetic nervous system through a supraclavicular and axillary route, utilizing anterior, axillary, or posterior approaches to reach the targeted nerves. This anatomical map highlights the precise resection boundaries. The surgeon removes the sympathetic trunk, starting from the lower half of the stellate ganglion, dissecting downward to just below the third thoracic ganglion. During this resection, all associated rami communicantes tied to the second and third ganglion are removed, and the accessory nerve of Kuntz is divided to ensure no collateral sympathetic pathways remain to trigger a vasospasm. But there is a specific preservation zone that must remain untouched. The upper half of the stellate ganglion must be explicitly protected and preserved. Operating in this dense anatomical space carries severe surgical risks. Complications include accidental perforation of the pleura, causing a pneumothorax, direct injury to the accessory nerve, or injury to the thoracic duct, resulting in a lymph fistula. If the surgeon fails to preserve that upper half of the stellate ganglion, the patient will develop Horner syndrome, an iatrogenic consequence resulting in a drooping eyelid, constricted pupil, and loss of facial sweating on the affected side. Managing Raynaud's phenomenon requires meticulous precision at every stage. A successful outcome relies entirely on strict differentiation, accurately separating benign primary conditions from destructive secondary diseases in the clinic, and perfectly separating targeted tissue from critical nerves in the operating room.